Causes of gallbladder are usually unknown. It could be diet related, but sometimes patients are predisposed to forming gallstones because of underlying problems, such as massive weight loss can predispose a patient to have gallstones, and also some other operations like traditionally a truncal vagotomy, or it used to take place in many years ago for ulcer surgery, ulcer treatment, and the patients were predisposed to developing gallstones. And you might have heard of famous 4 or 5 Fs: fat, 40, fertile, female, fair. Patients are predisposed to developing gallstones. But in my practice, I have seen patients developing gallstones regardless of their age, gender, and race. The youngest patient I have involved with gallbladder stone management was 11-year-old, and the oldest I've operated on is 94, and I've seen patients with gallstones at the age of 100. So it's I think because of a Western and refined diet, the causes of gallstone formation has varied over the past few decades. I think the gallbladder surgery is required when the patient has symptoms from the gallstones. And the symptoms can vary between recurrent mild pains, which usually starts in the under the rib cage on the right side, lasting for half an hour to 3 hours, and the pain can radiate to the back. It can be associated with feeling nausea or vomiting, and it can range between the mild pain to serious complications. Sometimes, gallstones can migrate into the main bile tube and cause either pancreatitis or obstruction to the liver flow, leading to patient becoming jaundice. So anyone with the stones causing symptoms or complications require operation. However, it depends on the patient's suitability to have a general anesthesia and able to tolerate the operation. By and large, majority of the patients are suitable for operation. Very small proportion of patients may not be suitable for operation. In that case, we have different forms of treatment. But if the patient is asymptomatic, which means they've been diagnosed with gallstones while having scans for various other problems, and in those patients, there is not a clear indication that they should have operation, and however, they need to be counseled regarding the operation and non-surgical management. Unfortunately, unlike kidney stones, gallstones are not amenable for ultrasound or laser treatment. So surgery is the mainstay of gallstone treatment. Not everyone with gallstones require operation. And for example, I was on call for general surgery in our NHS hospital this weekend, and I had a patient with gallstones at the age of 95. And I had the same conversation with the lady, and patient didn't want to have any operation. So I treated her with antibiotics, and she seems to respond to the treatment. But should she deteriorate, I may ask our X-ray radiologist to put a drain into the gallbladder to relieve any pressure from the gallstones. which is not what we call is a cholecystectomy tube, which is not ideal. But when you look at whole picture and look at the risk and benefits, I think the benefits of not doing surgery outweighs the risk. Nowadays, gallbladder surgery is done laparoscopically, which is a keyhole technique. Okay, the pain is milder compared to when we did open operations 20 years ago. So most of these patients can have a surgery as planned as a day case, which means they have the operation on the day and then they can go home on the same day. So they will be mobile immediately after the operation. Once they recover from anesthesia, they would be able to go home and recover in their familiar environment. And it is painful, and we therefore recommend the patient to have regular painkillers and also anti-sickness medication. Sometimes the painkillers can make the patient constipated, and we counteract that with a simple laxatives. The total recovery of a patient, it depends on the patient's attitude. I've seen some patients going back to work within 2 days of having a gallbladder operation to taking 3-4 weeks of time off. It is dependent on multiple factors, but I would definitely not recommend any patients going back to work 2 days after the operation. And my mantra with the patients is listen to your body, don't be a hero. Yes, the complications I explain to my patients is a general complication, because any operation is associated with the risk, such as infection of the wounds, infection inside, bleeding from the wounds or bleeding from inside, clot in the legs, what we call is a DVT, deep vein thrombosis, and clot in the lungs, pulmonary embolism. So these are a general complications to any operation. And then general complications to laparoscopic surgeries. While you're doing the operation, you're using instruments to handle the tissue. So that means you don't have a tactile sensation. So there is a risk of damaging structures like small bowel or liver or any other structures, because these are all surrounding structures of the gallbladder. But specific to gallbladder operation, there is a small risk of not being able to do laparoscopic surgery. In that case, we do open operation, even though it is a part and parcel, still should be part of the discussion with the patient. And very rare risk of damaging main bile tube can happen in 1 in 250 to 1 in 500 cases. In my practice, I quote them 1 in 500 because you have to state some numbers. And fortunately, my account is clear. No bile duct injuries. So the bile duct injury is a very serious complication, and lots of studies being done to look at how many operations patients would undergo after having had a bile duct injury. It's most of them would undergo major liver operations 2 or 3 times in their lifetime. But then you look at the risk and benefits side. If you see a patient with symptomatic gallstones, their risk of not having surgery is higher than having operation. So all the complications and description of the complications should be part of the fully informed decision-making process.